We now have a debate which Paul and Matthew very kindly agreed to do. And the important thing about a debate is that it's possible that neither of them believe at all in what they're saying, but they've been given one side of this debate or another. And so they're going to be talking about these two new vaccines. We're not going to see this decade, but we may well see them sometime after 2020. And what I want you to do now is to imagine it is 2020. As you can see, there's a really important decision which Jason Guy has to now make. And that is about these two vaccines which are now available. And in order to set the scene for these, so Group B streptococcus, you're going to hear about from one of them. I don't know who's speaking on which side of this, but Group B streptococcus is an important bacterial infection of neonates transmitted from the mother during childbirth. And RSV, we touched on a little bit this morning, an important infection, a viral infection of infants. And I want you to assume, we don't know the results of these studies yet, but I want you to assume that we have good data for both vaccines. They both have been designed for antenatal immunisation, so we're going to give these to mothers. Unfortunately, because the target wasn't reached for 2020 for the budget deficit, there's only enough money for one vaccine. And so what we've asked is these two experts here to present to you, who are JCVI today, to decide which of these two vaccines should be used. And so what we know about both of these is that they'd be given as a single dose at 28 to 32 weeks, and we're now waiting for the studies for giving it at 20 weeks instead of 28 to 32. They need to be given in every pregnancy, so you have high levels of antibody when the baby is born, and that they'll be 90% effective at preventing the disease in the first few months of life. There's been no safety concerns during the trials, and they cost the same amount. At least the NHS list price is about the same. So I think the reason why we have this is we're not really talking about cost effectiveness here. It's just trying to decide how you would weigh up the relative benefits of these two vaccines. So what I want to do here is before we now go over the experts, just to take a vote from the audience of which of the two vaccines you would go for today. And I will be asking you again after you've heard the presentations. So this is when you're a bit blind about the information. But who would like to vote for the Group B streptococcal vaccine? So there's a few hands. Okay. The GBS, the Group B streptococcal vaccine. So put your hands up again for Group B streptococcal vaccine. Okay, there's a few there. And what about the RSV vaccine? Okay, so at the moment we have lots of RSV fans, so someone has their work to do. So shall we have Paul going first? No, you've just been talking. Let's have Matthew first. I'm not sure which of them Matthew's going to talk about. We'll take a vote after he's... No, we'll let both of them speak, then we'll take another vote. Matthew.
Thank you. Here we go. So, I'm glad you agree with me. And that's where it is, I think, and so perhaps we can just leave it there. No, I'm going to tell you why you're right, okay, in terms of that there is an urgent need for antenatal immunisation against RSV. Now, I need to start with a disclosure. It's good practice to have full disclosure about any conflict of interest I may have, and this is mine. I really don't like RSV. I'm a paediatrician that works on the wards, and every year this virus ruins my life for 2 or 3 months of the year. Okay, why does it ruin my life? Because it causes, as you know, bronchiolitis. It causes other lower respiratory tract infections and can lead to secondary complications such as pneumonia. And it causes recurrent infections throughout life. I am sure I've had RSV every single winter for the last 20 years that I've been working as a paediatrician. But as we know, the greatest burden of acute disease is in the first year of life. Now, this you may not know, and this came as a shock to me as well, that RSV is second only to malaria as a cause of death in children between 1 month and 1 year of age globally. So there's RSV. It causes 6.7% of deaths in children between 1 month and 1 year of age. There's malaria, obviously, there's the biggest player, but there is no other cause that is rates higher than RSV in that chart. What about in the UK? RSV infection is the leading cause of hospitalisation in children under 1 year of age in the UK. And depending which study you look at and the methodology used, the admission rates are between 24 and 40 per 1,000 children. So that's around between 2.5% to 4% of children are admitted in their first year of life for RSV. Now that's for bronchiolitis, and I will apologise, I do use the terms slightly interchangeably, which is a bit naughty of me, because some of these are due to influenza, most will be due to RSV. The RSV alone attributed death rate in infants is 8.4 per 100,000 in the UK. And this seems to be getting worse for reasons we don't understand. That these are the admission rates. Now this is on hospital coding, so coding practices change over time, and as Andy mentioned earlier, admission practices change over time, so the thresholds to admit children might change over time, or parents might be bringing their children to hospital more readily over time, and once you turn up at a hospital then you're more likely to be admitted. But still, there is this dramatic increase in admissions for bronchiolitis over the last decade or two. And so that's where we get these figures around 40 per 1,000 children in the first year of life. And as we know, this predominantly affects young babies. And in the dark grey here, you can see those that are specific for RSV bronchiolitis. And that it's the peak age is 1 month. 1 month of age is the peak rate of admission, but then the vast majority, or the majority at least, occurring within those first 3 months of life. This, of course, you'll have already be tweaked to this, has implications for vaccine prevention of this disease, in that if we start in a routine infant immunisation program, we've already missed the bulk of disease here. Most of these infections occur in just a very narrow window, 2 to 3 months every year. And here's data from Public Health England looking at RSV in the black. The peaks of the number of reports of RSV infections received at Public Health England in a very narrow window every year. And look how it compares to influenza, but all but for the swine flu years and the recent year with the poor influenza vaccine match. RSV far outweighs any other respiratory infections in terms of reports to the labs. Now that's all illness, not necessarily admissions. And this is again reports occurring in a very narrow window. We all know it is October, November, December, where it's very busy. And here is an anonymised ward list, real ward list from my on-call that I did last November, where I think it was 15 babies admitted with bronchiolitis, just on a ward. This is one day, 5 of whom were in intensive care. I think actually the next day there were 7 ventilated babies lined up next to each other with RSV bronchiolitis. So this is overwhelming. And some of these babies are on the surgical wards, so these are the reasons that the operations are cancelled routinely every year in November or thereabouts. And in terms of treatment, we have oxygen, we have either nasogastric feeding or fluids, and nothing. There's nothing. Nothing works. Steroids don't work, salbutamol don't work. All sorts of medicines have been tried and failed. And so all we have is patience, which I don't have a lot of. And so these babies actually stay in hospital for 4 or 5 days. It's unusual in paediatrics to have an illness where it's even pneumonias are usually turned around within 1 or 2 days and go home. These babies take much longer than average, and so therefore are in hospital, and that contributes to their bed blocking. And this is why I really do not like RSV. So can we prevent this illness? What can we do about prevention? And you may be aware of Helovizumab, which is a form of passive immunisation. It's a humanised monoclonal antibody against the F protein, a key protein in the RSV surface. This is given monthly by intramuscular injection to at-risk babies during the RSV season. And so it does work. I won't go into the details. These are a meta-analysis of studies of at-risk children showing that, yes, you can reduce the burden of disease in these babies by giving monthly Helovizumab. But it is an expensive medicine. It is not cost effective to give it to the whole population. And in fact, this is the guidelines from the Green Book. showing exactly who is eligible to receive these vaccines, and really it's a very high threshold to achieve cost effectiveness. You have to have been born premature, and you're more likely to get it if you have chronic lung disease and so on. So this is not an intervention that's used widely at all. And part of the reason for that, if you look at this, 85% of the babies that are admitted to hospital for bronchiolitis are well, not preterm, and totally well babies, had no problems before this. So that's where the bulk of the disease is occurring. Pelivizumab is important because it can prevent disease in the very, very highest risk children, but it can also show us proof of principles that if you can give antibodies to babies, the right antibodies to babies against F protein, then it can prevent infection. And the immediate jump in is then, well, if instead of injecting those antibodies into the muscles, what if they were required transplacentally? And that's you can see where I'm going with this. It also provides evidence of potential for long-lasting reduction in disease from reduction in early RSV infection. What do I mean by this? Well, look at this graph. This is looking at the study of premature babies who received either pelivizumab or placebo. Now, they only get it in this study, they're only getting the first few months of life. But what you're seeing is an effect on later wheezing through their whole first year of life. So this is much longer, beyond the RSV season, beyond any direct impact of the pelivizumab. It seems that by reducing the RSV infections, severity of RSV infection or the numbers of RSV infection in early life, you avoid that baby having wheezing with repeated viral infections later in life. This is very important, interesting finding that may mean that preventing RSV can stop these children coming in with wheezing later in life. So I believe there is a crucial need for vaccine prevention of RSV infection, and this will need to be delivered by antenatal immunisation to cover these first few months of life, plus or minus infant immunisation to pick it up as the maternal antibodies wane. And so here we are in 2020, and I'm very glad that back in 2015 there was this massive vaccine program that launched by many different vaccine manufacturers to try and crack this problem, and that the leading candidate at that time in 2015 was a vaccine that's going into phase 3 studies in 2015 and 16. This vaccine is an antenatal vaccine against the F protein, and to just look at this, these are different formulations of the vaccine, and you can see that by giving this vaccine to women of childbearing age, that you induced antibody levels against the F protein that were 10 times higher than in those that got placebo. And those were protective antibodies. So not only did it induce an antibody response, but actually stopped the women that got it, they stopped them getting from RSV infections. If they got a placebo, about 23% had RSV infections. We're talking upper respiratory tract infections here. Whereas that was down to just above 10% if they'd received the vaccine. So this vaccine is inducing functional antibodies. We expect that these functional antibodies will be transferred across the placenta to the baby and provide protection in the first few months of life. This was a study that started in 2015, 2016, and is obviously crucial to the discussion we're having at the moment. So, in summary, RSV is second only to malaria as a killer of children between 1 month and 1 year of age. It's the leading cause of hospitalisation in the UK in children under 1 year of age. It is amenable to prevention through the administration of antibodies against F protein, I should read, and may prevent recurrent viral-induced wheeze during the first 1 to 2 years of life. I believe antenatal immunisation against RSV is an urgent priority for the NHS. It's not just me that thinks this. It's this chap as well. Okay. Thanks very much.
Thank you very much. I'm sorry that actually both speakers are Australians, but that's just how it is this year. We don't cheat.
I think you're very lucky to have 2 Australians here today. Right. So thank you for the opportunity. No, that's not mine. Just bear with me a moment. Is it this one?
No,
It's not that, is it? Might be this one actually. The introduction of the GBS vaccine will be a lot smoother than my opening of my... That's it, okay. So, yeah, thanks very much. So I'm speaking on behalf of the GBS vaccine, and I can see I have an uphill battle here. But I know that by the end of this, you'll be with me on this. Now look at this. Vaccine-preventable serious bacterial infections in children under the age of 5 in England and Wales. What are we vaccinating against at the moment? Men B, Men C, Men W, Men Y, invasive pneumococcal disease and Hib. This is Group B strep. This is Group B strep sepsis and meningitis in infants. And actually this is unfair on Group B strep because I say 0 to 4 years of age, but in fact all of this is in the first 3 months of life. We know that Group B streptococcal disease occurs predominantly on day 1 of life, and as you can see, relatively few cases and pretty much gone by 3 months of life. This is an ideal disease to be dealt with through maternal vaccination. We can look at these numbers in various ways. So if we look in the UK at the bacteria causing infection in babies in the first 2 days of life, it's well and truly up there, as you can see, by far the most common cause of bacterial infection in babies in the first 2 days of life. When it comes to after the first 2 days of life, it's number 5, but this is where it becomes a significant cause of meningitis. So this is our national surveillance study that we did a couple of years ago looking at neonatal meningitis, and half of all cases of meningitis in the first 3 months of life is due to Group B strep. That's particularly so in the first month of life, where you can see it's well above these other bacterial causes, and at the 3rd month of life it's only here that pneumococcus becomes more common as a cause of bacterial meningitis. This means for us in the UK that the incidence of neonatal meningitis has not changed over the last 3 decades. You can see that here. The incidence is unchanged over this period of time. Fortunately, the case fatality rate for neonatal meningitis has declined, but only here, and that's probably attributable to the introduction of better antibiotics, 3rd generation cephalosporins. But since the mid-1990s, there is no change in the mortality from neonatal bacterial meningitis, and that's all because of Group B strep. As I say, we can look at this in various ways. Here I'm comparing it with some relatively recent US data. This is all bacterial meningitis in the first 2 months of life, the top 5 pathogens, and Group B strep is so prominent here in the US as it is in the UK. The thing about meningitis, of course, in addition to the mortality, is the morbidity. So a couple of studies here showing that around half of babies who have Group B strep meningitis will have long-term disability, which is devastating. There are some other aspects of the burden of Group B streptococcal disease to focus on. One is pregnancy-associated Group B strep. Here we have data from the US showing that this is the incidence in pregnant women. The major point is that in babies it's come down with the introduction of antibiotic prophylaxis in labour. Late onset disease after the first 2 days of life has not changed, and it has not changed in pregnant women. And invasive Group B streptococcal disease in pregnant women is associated with significant morbidity. So here this is US data, but where the pregnancy outcome was known for mothers who had Group B strep in pregnancy, 61% went on to have a spontaneous abortion or stillbirth. And as you can see, a number of other morbidities associated with this. There are also what I might call known unknowns. We know that Group B strep in pregnant women is associated with prematurity. We know it is associated also with stillbirths. We don't know the size of that association, the extent of that association, and it will be very difficult to understand how big that burden is without a vaccine probe study. But nonetheless, it contributes to prematurity and to stillbirths. And even if it contributed to 1% of prematurity, because extreme prematurity is such an expense to our population, reducing or eliminating that would have significant implications. The current gold standard for preventing Group B strep in the first week of life, early onset disease, is by giving antibiotics to the mother in labour. And this has been truly adopted in the US, where all women are screened for group B strep, 35 to 37 weeks. They have a low vaginal rectal swab for group B strep, and if they're positive, they're given antibiotics in labour. This means that 30% of all pregnant women in the US receive antibiotics in labour, which is clearly a lot of antibiotic. So though we have a way of dealing with early onset disease in the first 6 days of life, first week of life, and particularly on day 1, through the use of intrapartum antibiotic prophylaxis, there are lots of problems with this, as exemplified in the UK, I think. Which strategy do we use to target the antibiotic? We know that with whichever strategy we use, there will be failures where the labour occurs too quickly, where the screening hasn't been done correctly, and so on, so where it will not work. It is an expensive approach to prevention, and perhaps most importantly, it has no impact on late onset disease, which is where the meningitis is, or any of these other pregnancy-associated group B streptococcal infections. We know, therefore, that a vaccine will be the most cost-effective means of preventing group B streptococcal disease compared to the other strategies that we currently have. So, what do we know about the vaccines? This is a cartoon of group B streptococcus. It's quite similar in some ways to the other bacteria that cause meningitis in children, because it has a capsule, a polysaccharide, a sugar capsule, and that indeed is the basis for the current leading vaccine candidates. There are other important structures here, surface proteins, which are also possible vaccine candidates too. And this is the current developmental status of the vaccine candidates. There has been a lot of work with the conjugate vaccines based on the capsule in the US over several decades, led by Carol Baker and her colleagues. This includes trials up to and including in pregnant women. More recently, Novartis, now GSK, have also moved forward with conjugate vaccines, and they have a conjugate vaccine which is now also being tested in pregnant women. There are some other candidates, as summarized here. Minivax, which is a protein-based vaccine, is the only one in clinical trial at the moment. So all the bulk of the work has been with the conjugate vaccine, and we're very familiar with conjugate vaccines. It's the basis of our infant immunization program to prevent meningitis. I'll just show you this slide, which is the slide from the US group at a serotype 3. There are 10 serotypes, but 5 account for most disease. This is serotype 3, which is the most common serotype. Tetanus, toxoid, conjugate vaccine. We're familiar with such a vaccine. Given to pregnant women at 30 to 32 weeks gestation. Lots of antibody at the time of delivery, which passes across to the baby, and even out to 2 months of age is well above baseline, which is way down here. You can hardly see it, the placebo group. So this provides optimism that this approach, vaccinating pregnant women, will protect the baby against early disease as well as late disease, which is where the meningitis is. We also know that these levels of antibody that are being achieved here will probably correlate with protection. We have a range of studies, and here's but one, and you can't see the detail, but it's a recent study looking at what levels of antibody are required to protect infants against group B strep, based on natural history, as it were. And from this, we are starting to derive levels which can be achieved, or which should be achieved in pregnant women to then protect their infants. And those levels are achieved in the studies that have been done so far. This means that in moving forward to licensing this vaccine, it may be that we don't need to do a large efficacy trial, which is very expensive and time-consuming. It may be that we can license such a vaccine based on its ability to produce levels of antibody which we know can protect infants. This, of course, is the model we've adopted in the UK with the Men C and the Men B vaccine. They were licensed not on efficacy studies, but on the fact that they were able to generate immunity. And coupled with that, we've had extensive post-marketing surveillance regarding effectiveness and safety. And that's all of the data that we're starting to see. Certainly we've already seen for the Men C, and we're starting to see with the Men B. Another really important factor is that this is a vaccine that women want. And these are data from our collaboration with Matthew and the team here in Oxford, and this was an online survey of women, and in summary, to begin with, 2/3 of women didn't know what Group B strep was. So there's an important public health message there going forward. We need to educate the public about this disease and this vaccine. However, when given some basic information about Group B strep, they could see how important it was. And 79% of them said that if it were licensed and routinely recommended, they would take this vaccine in pregnancy. That's really important. So I would suggest to you that the current strategies we have for preventing this important disease, the cause of meningitis, are satisfactory in some countries, but short-term and not realistic for many countries. I haven't mentioned the global burden of Group B strep. The burden in South Africa and Southern Africa is higher than that in the UK and similar to that of the US a couple of decades ago. But they can't readily adopt an intrapartum antibiotic prophylaxis approach. And as with other significant causes of childhood bacterial meningitis, I would suggest to you that vaccination provides the best prospect for successful prevention, and parents want it too. Thank you.
What we're going to do now is take another vote, and I'd like to try and look beyond the appalling Australian grammar and think about the content of the course. So let's first of all take a vote on Group B strep. Who would like to see Group B strep as the first? So, okay, and what about RSV? Interesting. Still some work to do. So I think what we'll do is we'll just see, has anyone got any burning questions before we hear the responses from the two debaters? Anyone got a question they'd like to ask them? No one has anything they want to come up with. Paul, you talked about the potential for strategies of vaccinating during pregnancy. Is that likely to be every pregnancy, or is it likely just to be in the one shot and providing long-term protection?
The answer is, of course, at this moment in time, we don't know. We do know the studies that have been done with the vaccine in pregnant women and in non-pregnant women and adult males show that the antibody levels persist for at least 2 years afterwards. But studies haven't gone on after that time. So it's likely that if this vaccine were to come in 2020, as you will all agree to shortly, then for the first part of the program, the vaccine would be given every pregnancy. But then we will learn from ongoing research and from the program whether it needs to be done every pregnancy, just as we are with the pertussis vaccine at the moment.
Okay, thank you. And Matthew, the RSV vaccine, we don't yet know how long it's likely to have persistence of antibody in the after birth. And that's clearly particularly important, since we still see hospital admissions right up until 6, 7, 8 months of age in infancy. If you look at the half-life of antibody for most transplacental antibody, a lot of it's disappeared by about 3 months, if not all of it. So is that going to be sufficient?
Well, Andy, I think I conveyed that in my slide earlier, that I think we are looking probably about 3 or 4 months protection. That is going to cover the majority of disease. But you might well want to cover.
Well, Paul's going to cover all of the disease with his vaccine.
But there's not as much disease to cover. You may well want to couple this with an infant immunisation.
Can I just ask about the numbers of deaths and children with morbidity afterwards, Paul, and how that compares with RSV?
Well, we know from in the UK from Group B strep, as I say, the most recent study, there were about 800 cases in babies less than 3 months and about 70 deaths, so just slightly less than 10% deaths. And we know in the meningitis cases, which are about 150 in the UK, about half of them will have long-term disability.
So we've got about 400 disabled children and about 70 deaths. How can you play against that, Matthew?
I think we can say 2.5% to 4% of the birth cohort every year are hospitalised with RSV. We do not have, fortunately, as many deaths. we do. Interestingly, the data is not all that strong in terms of the number of deaths from RSV. I did mention the figure there of 8 per 100,000 excess deaths from RSV. The methodology there is not great, and I think we don't know really, and I think that's important. But looking at that, you're looking at around 40 deaths a year from RSV in the UK. And I agree, that doesn't compare with this, and that's one of the interesting discussions to have about what do you want to prevent more, a rare but devastating illness, or a common illness that is occasionally devastating, but usually makes a child sick, but does not result in death or long-term disability, as I said.
Okay, should we? Oh, Amanda, let's have a question.
Is there data on how much money are we spending for each of those conditions for treatment and current
This is not an Australian love-in.
Great question.
Really good.
But which one are we going to save more money on? Which vaccine?
Which vaccine is going to save more money?
I think we need
Still save more money.
Paul, do you think we'll be able to drop
How much we call the
the screening program if we had a GBS vaccine? Do you think we'd be able to drop the screening program?
Well, you might argue that in the UK. But to be serious, I think that in any program we need to think about those who will slip through. And there will be those where the mother doesn't receive the vaccine for whatever reason. There will be the very premature infants, the discussion we had before. So we do need a way of managing them. And so I think coupled with the vaccine program will need to be a program around intrapartum antibiotic prophylaxis for those who don't get the benefit of the vaccine. So we wouldn't drop it in that sense, but in the UK it's a risk-based strategy anyways. There's no swab-based screening.
Can I also say that there's a psychological effect on the mother who actually miscarries or loses a baby in the late at 40 weeks full actual delivery?
Yeah. That sort of thing is not quantified, is it? It's not. Yeah.
Sorry, can you just remind me how many deaths from meningitis B were there, and what was the disability, just to get it in proportion?
So how many? The question is how many deaths from meningitis B? I mean, I know the figure for last year, but I'm happy to.
We're looking at around 400 or 500 cases of meningitis B and about 5% mortality, so it's around 20 to 30 deaths from meningitis B.
Yeah, I mean, so last year in the under ones there were 103 cases in the under ones of MB.
To what extent would you need to consider the implications for reducing the use of antibiotics when you're considering the Group B strep approach?
Yeah, I think this will also apply to the RSV vaccine actually, because I think there's a lot of antibiotic use around.
You're not helping your case.
I'm just being fair. Helping my Australian colleague. So you're right. I mean, we know that 10 to 12% of all babies get antibiotics in the first 24 hours of life. And the major thing that people are concerned about is infection, and that infection is Group B strep. So if you have a vaccine that prevents a significant portion of Group B strep, you will have a significant reduction in antibiotic use, unquestionably. And that has all sorts of potential benefits. So it's a very good point.
Oh.
So, Paul, you obviously said that you've done a study that shows that pregnant women would be willing to have this vaccination. Do you think, in terms of with RSV, is it applicable across the board? Are pregnant women happy to have these vaccinations in general? Or is there going to be a point where they're just like, not another vaccination, seriously, how important is it?
Yeah. Well, I think, I don't think we know how happy they would be to have an RSV vaccine. I don't believe we have any evidence on that at the moment.
Very happy.
And of course, seriously, it will be, of course, based on the information that is provided to them, based on the evidence, and it's really important to get that right. I think it's really important with the maternal vaccine program that we do get it right and that we continue to treat it very carefully, because it's been very successful in the UK so far with the vaccine. But anything that happens with a new vaccine that comes along such as an RSV vaccine, that causes concern, will then disrupt the whole program. So I think this is a really important factor. We need to assemble the information. We need to provide it in a digestible way and to convey the message. And I think we did show in the study that in fact we did with Matthew, or that Matthew did with us really, that mothers needed to know about group B strep first. There's a lot of education required first, but when they knew about the facts, then they were persuaded.
And I think one other thing to go into the mix there is if pertussis coverage is about 60% at the moment, with this rather odd system we have of someone having to remember to refer to the general practice, to then for practice nurse to be able to give pertussis vaccine in pregnancy when there wouldn't normally be a visit to see the practice nurse at that stage, and we still get 60%. If we had good systems in place, which sounds as if it may happen in the future, then it may be much easier to target and give the right information for both of these vaccines. And I think we should give the two debaters a chance to respond to... No, you can't say anymore. Give them a chance to respond.
I've still got some slides. I thought I had a...
No, we get to do that.
We're
going to give them a chance to respond to the comments made by their opponent. So, Matthew first.
Paul, I just want to start with a question to you. I do have some slides also. I just want to start with a question to you. Carriage rates for group B strep in pregnant women are around 30%, is that right?
21%.
21%. So that would be 80% of women that you're giving the vaccine to that don't even carry the organism. Is that right? You're immunising 80% of women who the chance of their baby having the vaccine is negligible. Is that appropriate, do you think?
Yes. It's actually it's about it's a quarter of women are colonised with the vaccine, and they therefore themselves are at risk of group B strep associated morbidity in pregnancy, and then obviously their babies are as well. But therefore, as you say, a significant proportion are not at risk. But of course, this is the sort of thing we see with any vaccine program. Most children will not go on and get meningococcal B disease. We know that as a fact. Yet we have to vaccinate everybody. So it's something about how a vaccine program works most efficiently. And of course, in the UK, we know that vaccinating routinely rather than selectively is the most efficient and effective way of doing it.
So, Paul Heath, there it is. Okay, so this is just talking about the risk factors. There are alternatives for prevention of group B strep, and I think this is important, that we can use antibiotics. There is no way to prevent RSV other than palivizumab, which is only going to be appropriate for the most high-risk children. But we do have an alternative to group B strep, and that is the use of antibiotics. We already know that 2/3 of the babies that developed early onset disease had an identifiable risk factor. If systems had been worked out to get those babies antibiotics appropriately, then this could have been prevented. So says Paul Heath. And look at the impact that a universal screening program can have, giving antibiotics. Look at the dramatic impact from around 1.7 cases per 1,000 down to around 0.4 cases per 7,000. This is the impact that universal screening and antibiotics would have. Yes, this meant that 30% of women are getting antibiotics, as opposed to 100% getting the vaccine. I think there is an alternative here, and this is what, of course, Group B strep support themselves are saying, pushing for universal screening with improved diagnostics to improve the prevention of Group B strep disease. We have an alternative. In an ideal world, of course, we would have money for both vaccines, Paul. I'll be generous and I'll give you that. But I think we do have an alternative here, and we need to emphasise, we need to push on prevention of RSV through antenatal immunisation. So I'll leave it there. Thank you for all the questions.
I think it's very rude using one's own data against. So thank you, Matthew. I think it's really important. Trust is really important, isn't it? In listening to an argument, we know that. And I think both Professor Dumbledore and Harry Potter would agree with me that Professor Snape is not a man to be taken lightly. So I've shown you that GBS has a burden in pregnancy. So these are the women who are being vaccinated. So for women, a Group B strep vaccine will protect them, their fetus and their infant. An RSV vaccine, the burden of RSV in pregnant women is uncertain or very little. So there is no benefit to the mother from the vaccine. The other striking thing that I've demonstrated to you is that all of the disease essentially occurs in the first couple of days of life. The peak, as Matthew has shown you, for RSV is a bit later. And that's important, and in fact Andy alluded to this, about whether the vaccine is going to provide sufficient protection, and in fact will not be sufficient in a program by itself. There needs to be something else, an infant vaccine as well. Whereas for Group B strep, all the disease is gone by 3 months, and that's when antibody will protect them. We've already talked about meningitis as being such an important entity for all of us, for healthcare workers, and as we have seen recently, particularly for parents. So anything that prevents meningitis will be something that people want to have. The mortality also Andy alluded to, and clearly there's more mortality associated with Group B strep. I think deaths, there are relatively few deaths. I think it's quite hard to quantify. There was a recent large population-based study from Sweden where there were no deaths due to RSV, but nonetheless the number of deaths are clearly fewer than due to Group B strep. Long-term disability we've talked about. There is uncertain long-term disability associated with RSV. There is the post-RSV viral wheezing that Matthew spoke about, but to be honest, the association with that and RSV is uncertain. There are various hypotheses as to the connection between RSV and post-viral wheeze, including the fact that they were going on to get it anyway. It's unrelated, relatively speaking, to the RSV. And in fact, Matthew touched on the alternative prevention strategy. Well, there is no other vaccine strategy. We can't give a vaccine to infants to protect them against Group B strep because it all happens on day 1 of life. He mentioned intrapartum antibiotic prophylaxis for early onset Group B strep, but we've shown in the UK, and I think I didn't show you a slide, which I should have, which shows that in our recent surveillance study, the incidence of Group B strep in the UK since our previous one in 2000-2001 has gone up. And that's despite a national recommendation on risk-based intrapartum antibiotic prophylaxis. The incidence, the burden has gone up over the last 10 years. There is no strategy for maternal Group B strep and for late-on Group B strep, late-onset Group B strep. There is no other prevention strategy available. There is the possibility, and indeed there are vaccines which are being tested for neonatal and infant immunisation because the peak is a little bit later for RSV. And then there's the issue about safety, and one of the things I said before is that we do need to be very careful and cautious about our maternal vaccination platform. We need to do it in a logical, we need to add to it in a logical and careful way. So the vaccine candidates that we have for Group B strep at the moment use traditional carrier proteins, no adjuvant, and the Group B strep capsular polysaccharide, which is the same, if you like, as the Group B strep, which 30% or 20 to 30% of women are colonized with. The RSV vaccines, there are a range of RSV vaccines, but even the one that is now in phase 3 trials is using novel proteins and adjuvants. So we do need to be careful about the safety of the vaccines. And so I think we add to this platform carefully because any evidence of or perceptions of safety will impact on the whole maternal immunisation programme. And I would suggest to you that doing it with Group B strep, for which there is a considerable burden that parents recognise, using vaccines that are vaccines we're more familiar with in terms of our infant programme, is a more logical way to do it. I should also say that I want an RSV vaccine for pregnant women. Thank you.
Great, so let's take a final vote. So those in favour of the Group B strep vaccine, hands up. And Those in favour of the RSV vaccine, hands up. So I think, despite winning all the previous votes, RSV has lost, and Group B strep won the final vote. So, thanks very much to both of the speakers. The actual process that there will be, assuming none of the rules change, is that as the vaccines become available and licensed, they get looked at on their own with cost effectiveness criteria. So it shouldn't, as the way things work at the moment, be a choice between the two vaccines. Each of them has to meet its own criteria for cost effectiveness. That's assuming they work and they're safe. And the evidence for that needs to be generated over the next 5 years before those decisions happen. So I think just to end the day, I'd like to say thank you very much to all of you for coming. And I think we should say a special thanks to all those who've been involved in organising, especially to Karen, who chaired the day and has put the day together. So thanks very much.